welcome to colleagues to join us for the ESMO 2025 The Power Talk, a new era in EGFR mutant non-small cell lung cancer. I'm Dr. Zhang from Yat-sen University Cancer Center. I'm a medical oncologist. Joining me is the co-chair of this section from Yale Cancer Center, Dr. Roy Herbst. So firstly, I will invite Dr. Roy Herbst to give some opening speech, please.
Well, ni hao.
Yeah.
It's wonderful to be here from Berlin, and such amazing data that we've seen at the presidential session yesterday here at ESMO. As a professor from New Haven, Connecticut, the United States, congratulations to all of you in China for the wonderful work you're doing. Both of the presentations were China presented and recruited trials, and we're seeing great progress. And today we're going to focus on EGFR mutant lung cancer. So I'm very excited to be here with my colleagues, and I look forward to an exciting program.
Okay, thank you. So next we will ask the Professor Fang, Wenfeng, also is my colleagues from Yat-sen University Cancer Center. She will give the briefly report of the presentation yesterday. So Professor Fang, please.
Okay. Distinguished Professor Zhang and Professor Roy Herbst, and dear our discussion guest and our audience online, I'm Wenfeng Fang from Yat-sen University Cancer Center. It's my great honor to be here to present this topic, SaciSac-TMT, reshaping the treatment of EGFR mutant non-small cell lung cancer. As we all know, that after the traditional chemotherapy, targeted therapy, and immunotherapy era, we enter the new era of ADC eras, targeting therapy. Actually, in fact, there is lots of ADC has been developed in the treatment of lung cancer. As we know, that the CHOP2 is a promising target for ADC in lung cancer. I think there is two main reasons. The first one is we know that the CHOP2 expression is very high in lung cancer. About 90% of patients have positive CHOP2 expression. The second is that the endocytosis activity of CHOP2 is very high in lung cancer cells. It's even higher than the HER2 endocytosis activity. Actually, there is two very famous CHOP2 ADC has been developed in lung cancer. There are Dato-DXd and SG, but both the Dato-DXd and the SG failed to meet the primary endpoint in the first three trials for unselected previously treated advanced non-small cell lung cancer. And both the two trials enrolled non-small cell lung cancer, including squamous non-small cell lung cancer and non-squamous non-small cell lung cancer, raised GR mutation and without GR mutation. But we can see that both the PFS and the OS was negative. So both the two CHOP2 ADC was failed for unselected previously treated advanced non-small cell lung cancer. As we know that the tisotumab vedotin is a novel CHOP2 ADC. The payload was a new top 1 inhibitor with the DAR was about 7.4 and with a clearable linkers. So the feature of the SaciSac-TMT is to release the payloads both in the tumor environment and the inside of the tumor cells, achieving a balance of the safety and the efficacy. Actually, at our prior study, we enrolled non-small cell lung cancer patients in a first one and first two trials. Totally, we enrolled 43 patients. There are 22 patients with EGFR mutation lung cancers and 21 patients with EGFR wild-type non-small cell lung cancer. we can clearly see that the efficacy was highest in patients with EGFR mutation non-small cell lung cancer. The objective response rate was 55% in patients with EGFR mutation non-small cell lung cancer, while the objective response rate was only 24% in patients with EGFR wild-type non-small cell lung cancer. And also, we can see the PFS is also better in patients with EGFR mutation non-small cell lung cancer. The median PFS was 11.1 months, compared with 5.3 months in patients with EGFR wild-type non-small cell lung cancer. Actually, this result was confirmed in another independent phase 2 trials. We enrolled totally 64 patients in this phase 2 trials. And the confirmed objective response rate was 34%, and with a median PFS 9.3 months. So we can clearly see that the SaciSac-TMT had achieved a better response in patients with EGFR mutation non-small cell lung cancer. So what's the reasons? What's the mechanism why SaciSac-TMT can achieve a better response in patients with EGFR mutation non-small cell lung cancer? At first, we think maybe because of the TROP2 expression, but finally we found that TROP2 expression level between the EGFR wild-type and EGFR mutation patients was comparable and similar. And there is no significant difference between the TROP2 expression. Then we think maybe because of the endocytosis activity may be different. So we overexpress the EGFR plasmids to the lung cancer cells with wild-type EGFR. Then we can see when cells transferred with mutation EGFR plasmids, we can see the endocytosis activity was significantly higher than the cancer cells with wild-type EGFR. So based on our clinical and translational study, we think that the EGFR mutation non-small cell lung cancer patients maybe is the widest, more effective patients for the SaciSac-TMT. So we conducted the OptiTROP-Lung 03 trials. It's a open-label, randomized, and multi-center registrational trials. And we enrolled patients with good performance and the advanced non-small cell lung cancer with EGFR sensitive mutation, and patients who progressions after prior combinations or sequential treatments with EGFR and platinum-based chemotherapy, and patients that were randomized to receive SaciSac-TMT or docetaxel until to disease progression or intolerable toxicity. The primary endpoint is the objective response rate by BIRC, and the secondary endpoint including PFS, OS, and safety. We can see SaciSac-TMT demonstrated statistically significant and clinical meaningful improvement in OR, PFS, and OS compared to docetaxel. And the objective response rate was 55% in SaciSac-TMT arms and 15.6% in the docetaxel arms. And the PFS, we can see the SaciSac-TMT significantly improves PFS over docetaxel with 70% lower risks of disease progression or patient death. Also, the OS data, we can see, even the OS data was not immature. We can see the SaciSac-TMT can significantly improve OS over docetaxel with 51% of lower risk of patient death. So, according to the promising efficacy data and manageable safety profile, and the SaciSac-TMT was approved in China in March 4th, 2025. So it's the world's first TROP2 ADC approved for lung cancer, and also this result was presented in ESMO annual meetings by Professor Zhang, and also the data of this trial was published in BMJ this year. And after we got the success of the SaciSac-TMT and the second line, then we moved to the second line. So we conducted another registrational study, the OptiTROP-Lung 04 study. It is a randomized multi-center open-label trials. Eligible patients with non-squamous non-small cell lung cancer with EGFR sensitive mutations who progresses after third generation EGFR TKI therapy or progressions after first or second EGFR TKI with negative T790M mutations. Patients were randomized to receive SaciSac-TMT or Plantin-2 and plus carboplatin or cisplatin based chemotherapy. And the primary endpoint was PFS, and the second endpoint including OS, OR, and safety. And the stratification factors including prior EGFR TKI therapy histories or brain metastasis. And this is the baseline characteristics. We can see the baseline characteristics of the two groups were generally similar and was consistent with the current clinical practice. I want to mention that almost 95% of patients received the third generation EGFR TKI either at first line or the second line. And we can see the primary endpoint PFS data. We can see SaciSac-TMT significantly improved PFS over chemotherapy, reached 51% lower risks of disease progression or patient death. The median PFS was 8.3 months in SaciSac-TMT groups versus 4.3 months in chemotherapy groups, reached a hazard ratio 0.49. And from the subgroup analysis of the PFS data, we can see benefits was consistent across all subgroups. And then when we move to the OS data, from this slide, we can see SaciSac-TMT demonstrated a significant and clinical meaningful improvements in OS. And even the OS data was not immature, but we can see the control arm, the median overall survival was 17.4 months, but the median overall survival was not reached in the SaciSac-TMT groups. The hazard ratio was 0.6. So we can see SaciSac-TMT demonstrated a clinical benefit with 40% of reduced of the patient death. So from the subgroup analysis of the overall survival, we can see a cross system of the OS benefits of SaciSac-TMT over chemotherapy was also observed in all predefined subgroups. So in order to predict the final OS benefits, so we used 4 different models to predict the final OS benefits. We can see the 4 models collectively showed that the SaciSac-TMT is expected to increase by 10 to 13 months OS benefits compared with the chemotherapy groups. So the OS benefit is very huge. And then let's look at the subsequent anti-cancer treatment. Actually, in the SaciSac-TMT groups and chemotherapy groups, about 32% and 85% of patients respectively received subsequent anti-tumor treatment. And there were 37% of patients in the SaciSac-TMT groups received pembrolizumab-based chemotherapy, and about 20% of patients in the chemotherapy groups received antibody-drug conjugate treatment after the chemotherapy. After the EGFR TKI treatment. Then we looked at the second endpoint, OR, DC, and the duration of response. We can see the objective response rate was 60% in the SaciSac-TMT groups, compared with 43% in the chemotherapy groups, and also the efficacy was durable. The median duration of response was 8.3 months in the SaciSac-TMT groups versus 4.2 months with chemotherapy. Let's look at the safety profile, and the instance of any grade treatment-related AE and grade 3 or higher treatment-related AE were similar between two groups. And the serious treatment-related AEs occurred less frequently in the SaciSac-TMT groups. We can see about 60% of grade 3 or higher treatment AE was accounted in the both arms. The most common treatment AE were hematological toxicity, including anemia, white blood cell decreased, and TROP2 targeting related AE were stomatitis. But most of them were grade 1 or grade 2, they are manageable and tolerable. So based on the promising efficacy data and manageable safety profile, the OptiTROP-Lung 04 study was presented at the ESMO presidential symposium by Professor Zhang, and also this data was published online in New England Journal of Medicine at the same day. Then let's look at the treatment landscapes for EGFR TKI resistant non-small cell lung cancer. Now, especially in China, we have 4 different regimens that can be used for our patients. We can use the TROP2 ADC from the optimal TROP-Lung 04 study, and also we can use the chemo plus the Avastin and plus PD-1 antibody from the ARENT 31 study. We can also use the Evosimab plus the chemo from the Harmony study. Also, we can use the AMIs plus chemo from the MARIPOSA-2 study. Actually, from the PFS data, both the 4 regimens have achieved better PFS than the chemotherapy. But when we look at the OS benefit, only the SaciSac-TMT from the optimal TROP-Lung 04 study, the SaciSac-TMT achieved a significant OS benefits with a hazard ratio 0.6. And also look at the safety profile. The grade 3 or higher treatment related AE was similar. It's about 60%, but the safety profile among the different regimens is different. We need to pay more attention to like SaciSac-TMT about the hematological toxicity or stomatitis. And for the regimens from the ARENT 31, we need to pay more attention to RAE or hypertension or protein neutral. But we also need to pay more attention to RAE and protein neutral for the Harmonist regimen. And for the MARIPOSA regimen, we should pay attention to the RASH and ILD and IR. So as we think the SaciSac-TMT achieved a good balance of the efficacy and the safety. So let's look at the summaries of the study of the SaciSac-TMT in EGFR mutation non-small cell lung cancer. After we get success in the second and the second of the SaciSac-TMT in EGFR mutation non-small cell lung cancer, whole patients progression on EGFR and chemotherapy at the second or progression on EGFR at the second, then we moved to the first line. Now we conducted a phase 3 trials of the TROP-Lung 07 study to evaluate the SaciSac-TMT plus the osimertinib versus osimertinib at TKI-naive patients. We also know that the SaciSac-TMT was licensed out to Merck. So means SaciSac-TMT was being explored in globalists at the third line and the second line for patient post the EGFR treatment. Summarized, SaciSac-TMT is the first and only ADC globalist to demonstrate a significant OS benefit in EGFR mutant non-small cell lung cancer who have progressed after EGFR therapy. Based on the result of the TROP-Lung 03 study, SaciSac-TMT has been approved for EGFR mutant non-small cell lung cancer who progresses after EGFR and platinum-based chemotherapy. Compared with the chemotherapy, SaciSac-TMT treatment in EGFR progressions to EGFR mutant non-small cell lung cancer, SaciSac-TMT can significantly prolong the PFS to 8.3 months, with reduction of the risk of the disease progression or death by 51%, and achieved a significant OS improvement with 40% of reduction in the risk of patient death. Based on the results of the TROP-Lung 04 studies, SaciSac-TMT has been approved by MNPA in China, becoming the first TROP2 ADC approved for the treatment of non-small cell lung cancer following EGFR TKI failures. So a first 3 study of SaciSac-TMT in combination with osimertinib as the first-line treatment for non-small cell lung cancer is currently ongoing in China. And last, I want to take this opportunity to thank all the patients and the families for the contribution to this trial, and also thank all the investigators for the valuable contributions. Thank you. Thank you for your attention.
Okay, thank you. Thank you very much, Professor Fang. Give us a lot of TROP2 ADC information, not only the Sac-TMT, but also the other TROP2 ADC, and also introduced the international developed plan of Sac-TMT in the EGFR mutant non-small cell lung cancer patients. So next section is that we will have a panel discussion. Before the discussion, we will have 2 persons co-chair these sections. I will just briefly introduce. First one is Dr. Chen Peng, or Peng Chen. He's coming from, also a medical oncologist, coming from the Tianjin Medical University Cancer Center. And another one is the next speaker. Next chairs is the Mengxia Li, which is also the chief physician, associate professors from the Army Medical Centers of PLA. I will transfer to these 2 monitors to chair this panel discussion. Dr. Chen and Dr. Li, please.
Thanks, Professor Zhang. Before this session, I congratulate Professor Zhang and Professor Fang as the leading PI on doing so wonderful work, and also congratulate SaciSac-TMT on obtaining the new indication for patients as the first-line systematic treatment. That will be help more and more patients in the future. 在这个阶段呢，我很荣幸配合
And for this part of the session, I am very happy to be like co-chair with Professor Li Mengxia. And so first of all, I would like to share.
Question for discussion is Professor Natasha Lian. She came from Toronto. She's a leader of the Thoracic Medical Oncology Program, Princess Margaret Cancer Center, University Health Network. She's also the OSI Oncology Foundation Chair in New Drug Development, co-chair of Economic Analysis Committee, and the Canadian Cancer Trial Groups. Professor Lian, okay, so let me introduce the second professor, is Edward Garin. He's come from California. She's the director of Thoracic Oncology Program and Johnson Comprehensive Cancer Center. She's a leader national and international phase 1, 2, 3 trials that secured FDA approval of multiple anti-cancer drugs and commission diagnosis. It's also the peer-reviewed funding for NIH and government programs and multiple foundation grants. The third professor is Professor Honinanti. She's come from Tokyo. He's Japanese national. He came from Japanese National Cancer Center Hospital. He's a director of Center for Education and Professional Career Development. He's also the leading of Office for Patient Flow Management. He is the Assistant Chief of Thoracic Oncology of General Secretary of Japanese Clinical Oncology Group.
We still have some Chinese experts, some of my old friends. We have Professor Hu Jie. Professor Hu Jie is from Shanghai, just like Geriatric Medical Center, Zhongshan Hospital, Fudan University, Minhang Campus. She has many of the academic titles. We also have Professor Liang Yuan, who is from Liaoning Cancer Hospital and Institute. And this is a very historical cancer hospital in China. And she has also led many of these different studies and carried many academic titles. We also have Professor Wang Lifeng. And Professor Wang Lifeng is from Nanjing Drum Tower Hospital and the affiliated hospital of Nanjing University Medical School. And she is the deputy director of the cancer center, and also she carries out many of the academic titles as well. Then we also have a Professor Zhang Lemeng, who is from Hunan Cancer Hospital. The affiliated cancer hospital of medicine, Central South University, and he also has carried out many of the domestic and international academic titles, including fiscal.
For the Professor Lian, Professor Herbst, the chair of this meeting, and Professor Hu Jie and Professor Wang Lifeng. The first is Professor Natasha. The question is, how do you evaluate the efficacy data from the Optiotrope lung study of SaciSac-TMT? And assuming all agents are available, how would you select the optimal second-line treatment for patients with EGFR resistance? Okay.
Thank you so much. And I have to congratulate Professor Zhang and Professor Fang on the wonderful work that you've done in this presentation. I think these data are so exciting, and I think they really establish in a randomized trial the survival benefit that our patients can get from a TROP2 targeting ADC with Sac-TMT. And so I think these data are wonderful. I believe they are practice changing. I hope soon the world will be able to change practice in many different parts of the world with a study like this and such an important publication. Right now, Dr. Darren and myself are very proud to be helping lead the Sac-TMT development in the rest of the world where, we're still catching up. We're hoping to replicate these data and to be able to make this available to all patients. I think it's really exciting to move these less toxic, more effective therapies up to right after targeted therapy, and to see now, with intensified first-line therapy, how can we sequence these different drugs? Should the ADCs come first? Should they come second after intensified regimens? So, I think this really is a leading regimen, and the survival data are very exciting. Dr. Herbst?
Yeah, I also congratulate the authors and all the investigators. This trial exceeded expectations, and I would say the expectations were already quite high. TROP2 has emerged through subset analyses from some of the early TROP ADC studies as an important target. I think as we heard in today's lecture, there are reasons why it might be a great ADC, not just the linker payload, but also the fact that it gets brought into the cell and there might be a spreading effect. The fact that there was a survival benefit in this trial with a hazard ratio of 0.6, meaning a 40% improvement in survival, I think is very compelling. And I think it's one of the reasons we see it published in the most high-profile journal. This is now going to influence practice, even if it's not approved in our country, my country, US. There are trials ongoing, but there are other TROP2 targets as well. I think, right now, we've made great progress in EGFR mutant disease over the last 20 years. But we don't really cure anyone. We have to always think about what's next. We now have multiple possibilities in the front line, whether it be the FLAURA2 regimen, which we also heard about at this meeting with chemo, whether it be a c-MET antibody approach, the Mariposa, or in some patients, EGFR inhibitor alone. But in any case, when they fail, and hopefully it doesn't happen for a long time, but almost all of them do, now we have a very good alternative treatment. And I think that the toxicity, while there are some was also a little bit less troublesome than I would have expected. So I think we need more experience with this. And of course, we will do more trials in the rest of the world. But right now, congratulations. And I'm very excited to have seen these data yesterday. And I'll now turn to Dr. Guerin for his thoughts.
Yeah, I think that the next, yeah.
I will just pop up. So first, I'd like to congratulate Professor Zhang and Professor Wenfeng for your fantastic work, and it's been a great, actually, a very great honor from all our Chinese doctors, physicians, and this is the first domestic manufactured TROP2 ADC who has reached a double primary endpoint, not only the progression-free survival, but importantly, the overall survival benefit in treating the EGFR TKI failed patients for the second-line treatment after the TKI. So this is, I will call it a milestone study. Yeah, it is totally changed the paradigm of treating EGFR mutant non-small cell lung cancer patients right now. So currently, as a Chinese, we are so fortunate. I think we have so many options to treat the patients. Not only the 3 or 4 combination regimens like harmony strategy or the 031 strategy, but now we have monotherapy, and even is the only one who have the overall survival benefit results. So this solid data, simple but effective, and also show a relatively higher overall response rate compared to the doublet chemo. So that's the simple, more directly strengthen efficacy. So that's it. That's also this is a fantastic work, and the efficacy will giving us more promising data to treat those patients who failed EGFR TKI. But here I read the New England Journal of Medicine, the full text, which published today together with this presentation on the ESMO, and in the subgroup analysis, I still see the data, but I have a few little questions. So if I have chance, Professor Zhang would give some answers, open explanations. So what about those patients who progressed has brain metastasis, because SaciSac-TMT is such a large molecular arrangement. So we do not see the positive results. It has a ratio, with those brain metastases. So are these patients we should pay more attention to? And the second question is about are there any preclinical data showing that there's a difference of the internalization of the EGFR 19 deletion versus L858R? So because we see the different subgroup analysis data between these two subtypes. So that's all my questions.
Thank you very much for your questions. So I think that I will leave the second question to Professor Fang. So the first question about the brain metastasis. Yes, this is a lot of concern about the using ADC for brain metastasis, because there was a big molecule which cannot transfer to the brain blood-bearing marrow. In these studies, according to the protocols, all patients with brain metastasis should be treated with radiation and stabilized at least for 1 month. So in these studies, only 20% of patients have a brain metastasis. That will, I think, raise some concern about in the real world. Actually, in the real world, I think maybe the higher incidence of the brain metastasis. So to solve these questions, so we see the DATO study. They have 3 arms, which is the one arm is continuous using TKI with the TROP2 ADC. This is one I think so one method to solve this problem. And then the other one method is we're moving to the first line. So that's why, so we have OptiTROP-Lung 07 study, which is a combination with osimertinib versus osimertinib. And when they combine this together, I think the osimertinib will control the brain metastasis, and we'll have ADC, which is a combination control the peripheral disease. So that will be, I think it's the better control of the brain metastasis when we moving to the first line treatment. So this is the, I think it's at least two methods to solve these problems. Either you continue use the EGFR TKI, even the patient with the progression from other side. I mean, not the brain, but because if brain metastasis progression, you need radiation therapies. So, but it was a combination with the EGFR TKI, either second line or first line will solve this problem. I think this is a way we trying to improve the brain metastasis control. For the second question, I will leave the Professor Fang to answer this question.
Actually, in our preclinical study, we truly found that the endocytosis activity was a little bit higher in lung cancer cells with EGFR LA5R mutations compared with the 19 deletions mutations. But I don't know why. But actually, in the clinical data, we found the efficacy of the SaciSac-TMT in EGFR LA5R mutation with the 19 deletion mutation, the efficacy is similar. So maybe we need more preclinical model to confirm our discoveries. Yeah, thank you.
Okay, thank you. Thank you.
The next question. Thanks for professors. Okay. Thanks for Professor Natalie. It's the first time to meet you. I want to know, Natalie is a very beautiful name in Chinese. And Professor Herbst, thanks for your role. And Professor Herbst is an old friend of China. He just visited our hospital 3 months ago. It's nice to meet you again. And thanks for Professor Hu for your question and thanks for the answers. Thank you. And the next question is a serious question. So the question is, how do you assess the safety data of the OptiTROP-Lung 4 study and compared to other platinum doublet-based or more agents combined therapy? What's the key advantage of this monotherapy approach? And the last is for the oral mucositis and stomatitis, what experience have you developed in your clinical practice? Thanks. Professor Garin,
yes, thank you.
Please.
Yeah, thank you. First, again, to congratulate Dr. Zhang, Dr. Fang on this work, as well as all the other people who were involved in this important study. I think that one thing that is a little bit different in the United States is that we have not had access to all of these drugs, and particularly ivonescimab, for instance, which is one of the comparators you're listing. We have only had access to it in the context of randomized trials. So I can't really compare because the patients that we have had on that trial, I don't know whether they were on the control arm or the study arm. I think that we have had certainly experience with TROP2 antibody drug conjugates, and I think that the strategies we have used are, certainly the mouthwash, steroid mouthwash has helped, and many of our patients, swear that sort of chewing on ice chips or having those in their mouth during the infusion has been helpful. I must admit I don't have randomized controlled data to back that up, but certainly anecdotally some of our patients have stated that. I think that the one of these studies that we have had access to in the United States really is the Mariposa data set, which incorporates amivantamab with or without lazertinib along with the chemotherapy. And there, it certainly is an active regimen. We have good progression-free survival data versus chemotherapy. We do not yet have overall survival data. The toxicity of that regimen certainly is real, and I think that while this regimen is a chemotherapy-based regimen and has real therapies, real toxicities associated with that, I think that some of those chemotherapy toxicities are also certainly going to be seen in the Mariposa 2 regimen, which does include a carboplatin-based regimen, but also the toxicities of amivantamab, which include a rash, which can be well managed in some patients, but can be quite significant in others, can be problematic. And the other issue, which is a short-term one, of course, is the infusion-related reactions. That is something that generally doesn't become a problem after the first cycle, but can be really bothersome to patients during that first cycle. Hopefully that will improve some with introduction of subcutaneous versions, but we don't have that yet, at least in the United States.
And I do find, those prophylactic steroid mouthwashes are also very, very helpful.
Yes.
But I agree with you absolutely, Eddie. I mean, these, as a monotherapy, it can be very well tolerated, these TROP2 ADCs. And it's nice that it is just one drug as opposed to many. Those are all potential advantages for patients.
So it's my turn. I'm Dr. Horinoshi from National Cancer Center, Japan, and I'm not be here at Berlin, and I'm very sorry about that. But only one participant from Japan, I'd like to take my maximized congratulations to Dr. Zhang and Dr. Fang to have the very fantastic data. So as to the safety, I think we have some kind of concern about the TROP2 related, TROP2 ADC related safety issue. However, when we check the clinical trial data, mainly phase 3 data, the cumulative grade 3 or more adverse events number in Mariposa 2 and also the OptiTROP-Lung04 trial is higher in the Mariposa 2. Now, in Mariposa 2, the grade 3 or higher TRA is 72%, and in the TROP2 OptiTROP-Lung04, it's only about the not only, but it's about the 58%. And also I'd like to highlight the TRA-related discontinuation rate. In the Mariposa 2 trial, we have the 18% of the patient who discontinued the treatment based on the adverse events. However, surprisingly, OptiTROP-Lung04 trial, there is no patient discontinued SaciSac-TMT based on the adverse events. That might be, maybe there's some kind of a variance in the clinical trial, selection bias or something, but the number itself is huge different. So I think that in comparison, the OptiTROP-Lung04 is some favorable safety, favorable selection of that regimens even in the safety point of view. And this comment has been well announced based by the Dr. Antonio Pasalo during the presidential discussion. Maybe many of the participants of this webinar should check the Dr. Pasalo's slide deck. It's summarizing concisely about the safety and efficacy balance. Thank you.
Okay, Maybe I think it's my turn. First, I'd like to say congratulations to Professor Zhang's team for your fantastic work. And also, I'm very glad to see my friend Professor Holino in this session. Actually, for EGFR TKI resistant patients, I think when we compare the Sac-TMT to other multiple agent regimens, I think the advantages are actually clear. So first, I think for Sac-TMT is more targeted. I think this means it has a wider therapeutic window and can overcome some like chemotherapy resistance mechanism. So even when I compare to the other active agents such as amivantamab or AK112 combination strategies, which have shown limited or uncertain overall survival benefits, we could see also from the like OptiTROP-Lung4's data, the Sac-TMT has also led to significantly better PFS survival and also overall survival benefits. And I think second is from the mechanism. I think the payload has a bystander effect, and also experiments in vitro show that the presence of EGFR mutations in non-small cell lung cancer cells also increase the Sac-TMT's internalization. And we also could see the data from the clinical trial. The Sac-TMTs demonstrate a higher ORR and also a deeper and more durable response. And third, I think which is most important is about the toxicity profile. Its safety issues also represent a non-overlapping toxicity compared to other combination therapies. So in my clinical practice, I think Sac-TMT is a favorable choice for TKI-resistant patients. Oh, that's all. Thank you.
Okay, thank you. It's my turn. First, I would congratulate Dr. Zhang and Dr. Fang for this fantastic work, and also congratulations Sac-TMT to reshape the EGFR mutation clinical therapy, clinical strategy. Based on these questions, I have several my points. I come from Hunan Cancer Hospital, so as for the OptiTROP-Lung4 clinical trials, we have a lot of patients enrolled in these clinical trials. So from my opinions, first, the safety profiles of Sac-TMT is quite consistent with unknown TROP ADCs. So I think the ICE, the safety profile is quite manageable. And also the second part, I think from the grade more than grade 3, the safety, the safety, and also for the mucositis is quite manageable. I think for the management of mucositis, from my opinions, I think the prevention, education, assessments, intervention, adjust are quite important. So from my clinical experience, I would do a lot of patients' education. It's quite essential and very important. And also pay still attention to the symptoms, self-examination before and during the treatment initiation. And also a patient can use the soft toothbrush and alcohol-free mouthwash. And I also think drink a lot of waters, and some clinical prevention can be used to decrease the incidence of the very severe mucositis. So for the mucositis, which is more than grade 3, unable to drink and eat, it's not a lot of patients. So I think the toxicity is quite manageable. So I think the safety profile is manageable. The severe toxicity is quite manageable. And I also think from the clinical education prevention, the toxicity is very manageable. That's my opinion. Thank you.
Okay, thanks for Professor Garen and Professor Zhang introduce their experience for treatment of mucositis in the United States and in China. And very thanks for Professor Annie Liangqi and Professor Liang make so much contribution to this trial. Thanks very much. And the next is now let us invite the partner Li Mengxia, professor, to moderate the next discussion. Thanks.
Thank you, Dr. Chen, for the introduction. And I'm very glad to be here as a monitor of the session. And I'm very sorry not to attend ESMO in Berlin. It's what a pity, because to express my congratulations to Dr. Zhang and Dr. Fang for the exciting work. And I think some more options for the EGFR mutant non-small cell lung cancer patients. So I think this is definitely lucky to be in China to have this option for the patients. So I learned a lot from the patient and the discussion, the two discussion before, and I will be monitor the next discussions. The discussions really actually Dr. Zhang answered the question from Dr. Hu about the so we have three session for this question. Professor Natasha Li, Professor Edward Garen, and Professor Liang. So please, do you guys can see the questions? Oh,
and thank you
all
so
right,
much.
So please, yeah, please.
Sure. So, I think osimertinib has, and all of the third generation TKIs have very clear CNS activity. And so in our practice, we still tend to discuss, we have a multidisciplinary team with radiation oncologists, surgeons, and medical oncologists. And we talk about each case in particular, if there are larger lesions, if they're in more challenging areas in the motor cortex, for example, we might recommend local therapy as well as the third generation TKI, which of course has tremendous impact. So it's always a discussion. There have been two very small randomized trials that we presented at World Lung last year that showed intracranial progression-free survival improvement when you add upfront radiotherapy, but the trials are very small. So, we do think about local therapy. Also very nice just to start with the third generation TKI, stable disease, asymptomatic, small lesions. This is a very good approach. I agree that as we intensify, we see very nice complete responses when we add chemotherapy. I don't think anyone knows why. We've also seen improved survival with FLAURA2 here at this meeting, also published in the same issue of the New England. And then also for amivantamab and lazertinib, again with the lazertinib, you do see that intracranial activity. So it is important, and this question of in a patient with brain metastasis, when they progress, what do you do with the TKI? Should you continue it? We have seen with the MARIPOSA-2 regimen, patients can progress in brain. Should we be adding the TKI back? It did start as a four drug study, but I think these are really important challenges. We have seen with other ADCs intracranial activity, even though it's not supposed to cross the blood-brain barrier. So I think it'll be really great for Sac-TMT to generate these data. Do we see additional intracranial activity because the blood-brain barrier is not so intact anymore with the brain disease and with radiation and other treatments? I do think for clinical trials going forward, we really need to be more permissive. We need to allow patients with stable brain metastases without local therapy. And I think that we really need to really drill down on the efficacy of these new drugs in brain and in patients with leptomeningeal disease. So common, so important, always excluded from trials. We need to change this. And I think in China we can. Eddie, I'll turn over to you.
Yeah. With everything you've said, I think one of the things that sort of has evolved over our careers is that historically, when somebody had multiple brain metastases, for instance, we would do whole brain radiation. And I think that several years ago, one of the things we would see in our practice are some patients who unfortunately would develop severe consequences of whole brain radiation. And they were radiated at a time when these drugs, these EGFR inhibitors, were fairly new, and we had a very low ceiling for what we anticipated. We didn't expect these patients to do very well. And then some of these delayed side effects came up over time. So I think that when we discuss these cases, oftentimes I sort of view it as a ratio between the number of lesions and the size of the lesions. So if you have innumerable 1 millimeter lesions, your choices really are going to be a whole brain radiation or relying on systemic therapy alone. I think when you have a limited number of small lesions, managing with radiation is more difficult, but reasonable for the patients. You don't know exactly, when is the right time to stop with the localized radiation, but oftentimes we will sequentially, every few scans, radiate a new area, and some of these patients can do reasonably well overall. I agree that this is going to be an important thing for us to evaluate now in the coming years. This is going to be an approval, for instance, without continuing a TKI. So the question is, what will the maintenance of brain metastases with this drug alone be at a time when we don't have a huge data set on combining with a TKI? And I think that probably for right now, for a limited number of smaller lesions, focused radiation is going to be a reasonable approach. And I think we're going to have to still work on the patients who have multiple brain metastases that are sort of small but throughout the brain, leptomeningeal disease, as you mentioned, and those are going to unfortunately be remaining challenges we have.
Okay. Yeah, thank you. Professor Liang. Okay. So Professor Liang's reply, so we just move to the next question. The discussion about the second after the line TKI, if you found that the patients have a amplification, second line when you will choose. So we have 4 discussants here. So please, Herbert, Professor Hironoshi, and Professor Liang, please.
Someone progresses on a first-line TKI, let's say osimertinib, and you do find c-Met upregulated, which is not uncommon. We are fortunate we have multiple treatments that we can use. Certainly, that wouldn't preclude using the TROP2 ADC as we've discussed today, but in a situation like that, and we're going to need trials to actually help us figure this out. We do have, for example, amivantamab or amivantamab lazertinib, because amivantamab does target, as per the Mariposa 2, does target c-Met, so that would be an option. There are also a series of small molecule TKIs that target c-Met as well. So those would all be options in that setting. Certainly we have the ADCs as well. I think what we're seeing now is that EGFR mutant disease is a disease of combination therapy. And it's a combination chemotherapy, ADCs, which are an important form of chemotherapy. By the way, at some point, it would be nice to be able to know what the TROP2 levels are and if that correlates, because that could be helpful. Looking at c-Met, looking for other alterations. Sometimes when someone recurs, there's another driver mutation. So I think we're talking about now an era of precision EGFR targeted therapy using biomarkers and to help with our treatment decisions. But the nice thing is we have this armamentarium of new agents, which will hopefully improve outcome. And then, of course, we have to consider brain disease, as we've just talked about.
So as Dr. Herbst mentioned, because we have the several c-Met targeting treatment options like a TKI, and also we are going to have the c-Met ADCs in future, like the telisotuzumab aditotecan or telisotuzumab, especially in US. So in that case, maybe such kind of option will be the favor option. However, during this TROP2 ADC Sac-TMT session, I'd like to share our experience in our institution. We have conducted a paired biopsy multiplex protein expression analysis. It's not the amplification, but merely the overexpression. But when we check the MET overexpression and TROP2 expression in our study sets, all of the patients who relapsed after EGFR TKI show the MET plus TROP2 overexpression. When the patient have the MET overexpression by the protein expression, all the patients have the somewhat level of the TROP2 expression. That might be some clue for the TROP2 ADC in this field. And of note, among them, the TROP2 high expression based on the H-score is half of them. So I think that even in the CMET overexpression patient population, there might be some space for the TROP2 ADCs. So as Professor Herbst mentioned, we need some kind of clinical trial targeting such kind of patient, both expressing the CMET and also TROP2 or something. Thank you.
Thank you. Professor Hu.
Yeah, and this is really a good question because we have currently the Mariposa and also this Sac-TMT both showing in the all-comer EGFR treatment failed patients, they both can have reached like 6 to 8 months progression-free survival data, and but the thing is to treat the EGFR acquired MET amplification patients. The doublet MET TKI with EGFR TKI is still one of the options because this year's study also showing that they can also have reached like 8 to 9 progression-free survival. So the difference between these two doublet orally administered strategy is they are so convenient and is chemo-free, so many patients will willing to choose this non-toxic or less toxicity doublet combination. The Sac-TMT is still giving 2 weeks. 2 weeks to give 1 dose, so it's quite inconvenient in the clinical practice to use. So this is one of the concern. And the other thing is, I think, is that the Sac-TMT is still a chemo-based mechanism. So the toxicity is sometimes it is well manageable. It is manageable, but still have some toxicity compared to the doublet TKI. So this is only for those patients. I think only for those patients with a relatively high amplification number of the MET, such like the MET, like this MET with the NGS is higher than 10 or higher than 6. According to last year's data, is the amplification. The threshold of amplification should more than 6. So that will be more confident to use the anti-MET treatment for my comments. And the other thing is those patients who has progressed of pre-metastasis and the small molecular tyrosine kinase inhibitor, they will have relevant higher efficacy to treat those pre-mets patients. So these are the 2 concerns to use to treat those MET amplification patients. Otherwise, I think it's all common to use the Sac-TMT. That's all my.
Okay, thank you so much for the 3 professors' opinion on the CMET amplification. So because this whole time of this meeting is with the old time, so I will according to we will just stop here for the 4 discussions, and I will give my speak for Professor Zhang and Professor Royal Herbst for the closing remarks, please.
Very much. I think it's we have a very informative discussion and about the EGFR mutation treatment, either the second line or last line. So we talk about the toxicities and safeties for SaciSac-TMT, and we also talk about the efficacy. I think it's very important right now. So the drug is last week is approved by the indication in China. So it's right now we have third line indication and the second line indication already. So I think it's not only published in New England Journal of Medicine, we really change our practice in China because the data was already approved by regulatory authorities. So also I think it's they will have come to the reimbursement list at the end of this year. That means there will be the price of the drug will be lower and more easy for the access for our Chinese patients. So I think thank you very much either for our overseas colleagues and also thank you for our domestic colleagues, which is a very informative comments and discussions for these sections. And then I will move to Dr. Herbst.
Right. Well, this has been a wonderful session. We've seen wonderful data at ESMO. I think now we certainly have a new weapon in the war against EGFR mutant lung cancer, the Sac-TMT. This trial really was positive across all the endpoints. We're in an interesting era. It used to be patients from China would come to the US to get new treatments. Now patients from the US will need to go to China. I just want to say one thing as we end. We've been working on EGFR mutant lung cancer for a long time. We've seen great advances. I must say personally, when we heard about EGFR mutations and we had these new drugs, the thought would be that we could use these agents alone. That's not going to be the case. Resistance is a major issue, so we're constantly going to have to fight to develop the right combinations. We're seeing here now that we have many new ways of treating, either adding new molecular therapies, adding antibody drug conjugates, targeting c-Met, and there are going to be other resistance mechanisms that emerge as we continue to change the paradigm. So we have to continue to ask the questions. What sequence do we use these agents in? Let's bring our best and newest agents to the early stage disease. You can imagine frontline therapy. Let's not forget adjuvant and neoadjuvant therapy, therapy after stage 3 disease. All these possibilities remain. We have to think about also monitoring minimal residual disease, when to change. But we can't do all that if we don't have the agents. And I'm thrilled that at this ESMO meeting here in Berlin, we've seen this wonderful new agent, and it's great that we've had a great discussion today. It's wonderful to meet all colleagues from around the world, and thank you for including me today.
Thank you.